Hello everyone, I'm Dr. Angela Mattke and you're watching Ask the Mayo Mom on Mayo Clinic's Facebook Live. I'm a pediatrician at the Mayo Clinic Children's Center, and twice per month I host a show about pediatric health topics where we take and answer your questions live. July is National Cleft and Cranial-Facial Awareness Month, and cleft lip and palate are also the topic of our discussion today. Each year, thousands of babies are born in the U.S. with clefts. Our goal today is to promote awareness of this condition. Joining us today are two talented Mayo Clinic surgeons. The first is Dr. Shelagh Cofer, a pediatric ear, nose, and throat surgeon, and assistant professor, as well as the chair of the Division of Pediatric Otolaryngology. Dr. Cofer is also the director of the Velopharyngeal Insufficiency Clinic. Our second guest is Dr. Samir Mardini, a plastic surgeon and professor of surgery at Mayo Clinic. Dr. Mardini is also the chair of the Division of Plastic Surgery and co-director with Dr. Bite of the Cleft and Craniofacial Clinic at Mayo Clinic Children's Center. Please join the discussion today by sending in questions under the Facebook Live video feed. And we'll try our best to review them during our live video broadcast, but we'll get to them after the show if we aren't able to address them during the show. Dr. Cofer, Dr. Mardini, thank you so much for joining us today.
Thanks for having us.
This is going to be a great discussion. So both of you take care of children who have cleft palate and cleft lip. Can you tell us a little bit about your roles in that process?
Sure, of course. So we have a very busy cleft team, and Dr. Mardini is co-director of that team. We see hundreds of patients a year in our cleft team, and so that's what we spend a lot of our time doing.
And you had mentioned right before the show that you were actually operating on a child with
we just did a cleft lip this morning.
Okay. Yeah. And Dr. Mardini, tell us a little bit about your role in seeing children here.
So I think one thing that really is important to note is the multidisciplinary team that we have at Mayo Clinic. I mean, you see us here. We have Dr. Cofer's ENT on plastic surgery. We work very closely together to care for the patients. We have other members of the team that are critical. We'll talk about them a little bit later.
Absolutely.
But we believe very strongly that these patients, when they come in, it's not one person that can take care of them. It requires a team effort, and we provide that very well here at Mayo Clinic.
Okay, let's get started by understanding and talking a little bit more what exactly cleft lip and cleft palate are. Dr. Cofer, can you take us through describing this?
Sure. So cleft lip and cleft palate are essentially developmental problems that during development, usually the first trimester, there is failure for fusion of the lip, and that occurs by about 8 weeks of age. And then a little bit later, at around 12 weeks of age, where the palate shells do not fuse together. And so there's a range, and I think we have a picture of this. There's a range of degree of cleft, and sometimes it can extend, for example, in these pictures, all the way into the nasal passage, and sometimes it just is a little bit less severe and it extends only partially. And when we're looking at the palate, in the next picture, we see that the palate is really the roof of your mouth, but when you think about it, it's also the floor of your nose. And so you've got the palate, which has a hard portion in the front and a soft or muscular portion in the back. And we see that you can have any portion of that palate that is open, and that's essentially what a cleft is.
I think a lot of people don't necessarily realize that your nasal passages are going to be coming in right in the back of where that palate should have been closed. Is that something that you also have explained to families, or?
Yeah, we really have to kind of go through the procedures that we do step by step, and we want to close it because it affects their feeding, it affects their speech, and just for general health and hygiene, we need to get that closed.
Absolutely. So how common do cleft lip and cleft palate occur?
It depends really. To answer that question, I think you need to think of which population you're looking at. So in the United States, if you're looking at, it's a little less common in certain groups. So for example, African Americans, it's about 1 in 1,500.
Okay.
In the Caucasian population in the United States, it's about 1 in 1,000. But there are certain areas in the world where it's vastly more common. So in South America and Southeast Asia, you can see incidences as frequent as 1 in 300 births.
Do we know why that it's much more frequent in certain populations?
So it's really a combination of genetics plus environment and the interplay of those things.
Okay. So Dr. Mardini, are cleft lip and palate, how how often do they occur together, and are they related?
So they are actually separate entities,
Okay.
but they do often happen together.
Mm-hmm.
And because the clefting can happen, there's a primary there's an anterior part which includes the lip and the anterior part of the palate, and then there's the secondary part which includes the back part. So if you're looking at cleft lip and at least part of the palate, it happens 50% of the times they happen together. 25% of the time it's just a cleft lip, and 25% of the time it's just a cleft palate, at least part of the palate. So they definitely occur together quite a bit, and even though they are separate, they do happen to happen at the same time.
Dr. Cofer, you can jump in on this. You mentioned a little bit about genes and causes. Do we know if there's certain genes that are identified with the development, Dr. Mardini, of cleft palate or of cleft lip, or them being present together?
So we do know that the it's genetic, and the cause of it is genetic and environmental as well. It's multifactorial, and I think it's very difficult to pinpoint one cause of this. There have been a couple of things that we tell patients to do and not to do if their concern is, smoking may have higher incidence, but it's not totally clear. So we'd say, please, try to stop smoking if you can. And then there's been maybe an association with a deficiency in folic acid. So perhaps taking some of that might be helpful. But beyond that, I don't know that there's any clear, and maybe Sheila, you can weigh in. I don't know if there's any clear. There's some genes that have been identified. But environmentally, I'm not aware of anything else that's clearly identified as a cause.
Yeah, it's hard sometimes to pinpoint. Most often it's just, we say sporadic. It just sort of happens from the right genetic deck of cards plus the influence of the environment. And there are some genetic differences that have a higher incidence of cleft. For example, some of the babies with Down syndrome or other genetic differences, we can see a higher incidence.
So some syndromes have more associations with them.
That's right.
Okay.
There are at least 300 syndromes that are actually associated with clefting. So it definitely is strong link with syndromes.
Okay. When would the first indication of this being present in the child occur? Would this be prenatally be determined on ultrasound, or when are parents going to find this out?
So in most cases, I would say in this day and age, the ultrasound imaging is so detailed that they're able to pick up whether or not there's a cleft lip. The cleft palate is a little bit harder to see. So if it was just a palate that was involved without the lip, sometimes we miss that.
Right.
And even when we do see a cleft lip on prenatal ultrasound, we always can't say for certain if the palate is going to be involved. So we just wait until the baby arrives and examine the child at that time.
Do you ever see the parents prenatally to discuss the diagnosis, or is that something that usually happens after?
We do. We prefer to see them prenatally because that's an opportunity for educating them, having their questions answered, reviewing at least to the degree that we're able to what to expect over the next few years.
And some of those things that you're preparing them to expect probably have to do with their growth and feeding and stuff. How does having a cleft palate or a cleft lip present affect their growth and their feeding?
So that's a really important point because the most important thing when the child is born is to come up with a way to feed your baby.
Right.
And we have such a great team of swallowing specialists that will come and help, and there's almost always a way to figure it out. It is true that if you have a palate, there are some more feeding challenges than with just the lip alone.
Right. Right. We have some great questions about the surgery and the timing of the repair. One of the audience questions is what factors do you determine and do you take into account when deciding when to proceed with the repairs?
I want to add to Sheila's point about when we see a patient either prenatally or when they're first born, we have such pleasure in telling them that their kids are going to lead normal lives. I mean, we have so many good techniques and such a good team, and it's just so comforting for them, and we feel so good about telling them that these kids are going to have a great repair, they're going to have great results, and they're going to be just like anybody else. And the timing of the repair is critical, and there's many things that are factored into that. If the baby has a cleft lip and a palate, we do the cleft lip as early as anesthesia is safe and when the child is big enough, and that's usually about 3 months.
Okay.
Sometimes they end up having some nasal-alveolar molding and things like that beforehand, and it may delay things a little bit, but it's around that period of time. And then the next phase is when they're going to get their palate repaired. And we are concerned about the growth of the face and the maxilla with the surgery itself. So we like to postpone it for that reason and do it as late as possible. On the other hand, if you postpone it far enough, the speech will be affected. So picking the right point of time when to do it is a critical thing. And most centers are doing the repair of the palate between 1 year and 1.5 years.
Okay.
Before the baby starts to speak, when they're starting to say da da mama, things like that. Generally we're here repairing them around 1 year of age, but there are centers that are doing the repair at around 18 months.
Okay. Are there ever surgeries that are required after the initial repair?
So we tell the families that there are stages in the repair of cleft patients, and so following the repair of the cleft palate, the patient will follow with us in the clinic. If there's any speech issues, which happens in 10 to 20% of the patients, they get seen in Dr. Cofer's VPI clinic and get assessed for whether there's a problem that needs to be fixed, and that could be fixed around that period of time, which is somewhere between 3 and 4 years of age, or around that period of time, when they're starting to speak well enough that you can make an assessment of them. And then there's a window of opportunity before they go to school to do revisions. If they have a nose that's not perfect, or if they have a little notching in the lip or something that needs to be repaired, that's a good point to do it before kids start to notice. There's also many of the children have a clefting in the bone in the alveolus, which we repair before some of the teeth erupt, and that happens around 9 to 11 years of age.
Okay.
And then there's further things along the way. Some of them may require jaw surgery if the jaw is protruded in some areas, and some of them will require nose work and things like that over time.
We have a picture of kind of what the repair process looks like over the years, and so let's pull that up. Can you just kind of walk us through this, as you mentioned, where you might consider surgery later in school, what we're seeing here?
So you can see first the baby has a cleft lip. That's a deformity that you want to address quickly, but you don't want to do it the next day. You do it when anesthesia is safe, that's 3 months. And then they get the palate repaired around 1 year to 1.5 years. And then before they go to school, there's sometimes some things that they're noticing that the child might say, or the parents more often are noticing it at that age, and we fix that in a very small revision surgery. And then over time, many patients don't need anything else after that. But if they do, then they do, and it's just a simple operation, and we do it, and the child moves on.
Yeah. I noted that you were talking about the nasal alveolar molding. Can you say a little bit more about that? Because that's a great thing that we have available here.
Yeah, so Dr. Cofer and I, we both work very closely with the orthodontic team here. They're talented, and what they do is they're able to, because they didn't fuse together, they end up falling in different places in space, I suppose, and sometimes they're not aligned at all and they're very far apart. That also creates a collapse of the nose. And the nasal alveolar molding is basically almost like orthodontics, like we have braces and things like that when you have teeth. There's no teeth obviously here, but they have some devices that are placed and that are molded, and over time, it's more similar to Invisalign. So they're molded over time. We see them often. Molded devices, the segments of the palate start coming closer together. There's actually a little, as you're mentioning, there's a little pin that kind of holds the nose up and shapes the nose as well.
So we really are taking advantage of the fact that these babies are so plastic. It's almost like they're made out of silly putty, and we can make them go where we want to make it favorable.
Exactly.
Yeah.
And that helps us a lot. It makes the positioning of everything so much more favorable to get the bony part closer to each other, but also to have enough redundancy in the tissues to get optimal results and not less notching and things like that sometimes you may see.
So you guys are seeing them in a clinic pretty frequently and over most of their childhood, it sounds like. What are some of the health concerns that you guys are addressing as they get older, besides looking at the alveolar nasal ridge and those things?
So when they're newborns feeding, we like to get that up and going, and then Most kids will see speech pathologists along the way, and they may need some speech therapy. That's a big part of it all. Also, if they have a cleft palate, those kids are at high risk for having some issues with their middle ears and developing fluid in the middle ears. They might go on to need some ear tubes placed. There's so we monitor for that, make sure we're getting their hearing checked, all to help out with their speech in the long run. And then they also will have contact with the dentist on our team, the orthodontist for braces, and all of that later on too.
What age does the dental involvement usually start? Does that start as soon as their teeth eruption happens, or is it more when their permanent teeth are starting to come in?
So initially, we want them to just see any pediatric dentist in their community because dental health, but once their mixed dentition is there, we really need the input of the specialist on the team to look at the timing, to guide the timing of, if the gum line needs to be grafted, and straightening and sometimes expanding the upper jaw to get things prepared for the bone graft. So that's all determined a little bit when they're a little bit older, maybe 5 or 6.
Okay.
But that's why we have them come back every year to the team, and we all sit down in the same room, and we all talk face to face. It's very collegial, and I think it's great for patients.
Let's talk a little bit about that team. Who's involved in the team of the care of children who have clefts?
It's everybody.
Yeah,
So we have a genetic specialist, we have plastic surgery, oral surgery, the dental people. We also have a neurodevelopmental specialist and a social worker, and just to kind of look at all the different aspects of health. I mean, yes, there's a physical problem that needs a surgical correction, but there's a lot more going on, and so we like to make sure that there's a nice holistic approach to all the different issues that come up.
Do you have anything else to add?
Yeah, and some of the patients, as we were mentioning earlier, they're very complex. Some of them have syndromes. We also have pediatrics involved in helping us arrange appointments with other services that are not necessarily part of the clinic, but we definitely work closely with, like ophthalmology or general pediatrics, developmental pediatrics and things like that. We have a lot of patients that come from far away. And when we're talking about making it convenient for them, if they're going to see 7 or 8 specialists, it's very hard to do that if they're going to just make their own appointments. So we coordinate it for them. They come in within 2 days. They've seen all the specialists. After we see them, we sit down together. We have a lunch meeting, and we just talk about each patient individually. And that's very, very productive because everybody hashes out all the, puts out all the opinions out there. We discuss things, and then we come up with decisions that we can also share with the patients, and then make it convenient for them. So if they do need a procedure, we can combine that sometimes with the clinic.
That's a great point.
Yeah, so a lot of the patients, because they come from 5 hours away, 10 hours away, we're all on board with making this work for them for the visits and as well as for the surgery.
Absolutely. I remember when I was in residency and I got to sit in on that clinic. I think I was working with you that day, and it was amazing to see the collaboration that occurred. I think that's really a strength that we do have at Mayo Clinic, where we can work with people who have very complex medical diseases and bring everyone together in an efficient manner, best for the patient. So, yeah, I was very impressed. That was many years ago. So you guys have been having this clinic for quite some time. It seems like to.
Yeah. Do you know when it first
I don't know when it
started?
started. I've been here for 12 years. I know it started way before that, so it's probably at least 20 years, 25 years,
I would think
or
so.
even further. Yeah.
Sometimes the parents are bringing in their children, and the parents
That's
had
right.
clefts fixed here at Mayo,
That's
and
right.
now
That's
their
right.
baby has one.
So now that I think about it, there was Dr. Ian Jackson was here at least 20, 30 years ago, and I know that he had the clinic back then. So
Yeah.
we have a strong history.
Yeah.
You must be developed really special relationships with the families and the children as you see them year after year. I imagine that's very rewarding for you guys.
Yeah, I think that's a great observation, and I think, one of the great celebrations that we have is when a patient does graduate from our Craniofacial clinic, but it's also sad because you don't get to see them anymore, but most are out there going on with their life.
Absolutely. You have a little model sitting here on the table. Can you tell us a little bit about this?
Yeah, I don't know if you're using this at all, Dr. Mardini, but it's an example of some newer technologies. This model that I have is basically a soft silicone or plastic type material that's clear,
Yeah,
it's
so we hold it up a little
transparent, and it's made entirely by using a device that surface scans
Uh-huh.
the surface of a baby. So this was made from a baby, just a normal newborn.
Okay.
And just by holding up a device over the top, and then they're able to print this, which is fairly accurate rendering. So we're starting to use these a little bit more for individual patient care, and then also for education and teaching of our trainees as well, where we could make one of these, do our surgical planning, let our residents do the markings in practice, and this is a very simplified one, and I think there's only going to be more and more complexity and realistic renderings in the future.
You mentioned doing the markings. What does that mean? Can you explain a little bit more about that?
So when we have the cleft, we like to use, we design it out. Some people use different techniques, and we have to carefully mark the landmarks and then open up all of the edges of the cleft, and in order to restore the form and the function, we have to get the muscles together. So
that's very cool. Very cool. And Dr. Mardini, you have used 3D printing in the past to help with your surgical planning and stuff. Can you tell us a little bit more about that?
Yeah, so I think, again, back to the point that, being surrounded by such great teams here at Mayo Clinic outside of the Cleft team allows us the opportunity to continue to innovate and also take advantage of the tools that we have. So we have a phenomenal radiology team, like Dr. Cofer was mentioning, laser scanning, 3D printing. We use that for a lot of the other reconstructions we do. For facial reconstruction, other reconstructions. So we do, we involve a team of residents in the surgery, as you were mentioning, but this is a type of surgery that we are very careful to do ourselves, making sure that all of our, because the baby, as you can imagine, as you know, is there's no room for error. So these are surgeries that we make sure they're done perfectly and done by us and the team. So. The Mayo Clinic, the way it structures, forces us to be in teams, and it makes it so easy to do that. And I think we always benefit from that.
Absolutely. Both of you had mentioned earlier children who have cleft palates that they may be at risk for VPI or velopharyngeal insufficiency. Can you talk a little bit more about what those symptoms would look like and what kind of the treatment would look like?
Yeah, so as Dr. Mardini was mentioning, sometimes about 10 to maybe 25% of those patients who had a cleft palate repaired initially, they might sound a little different. And if our speech pathologists bring that to our attention, we need to check them to see, does the soft part of their palate make a good contact or seal for certain sounds with speech. And so symptoms might be sounding too nasal on certain sounds where we want to get a tight seal and have all the air come out the mouth. Another symptom could be nasal regurgitation, where when they're swallowing, boom, all of a sudden they get a Cheerio up the back of their nose or some water comes out their nose. So if that's the case, then we like to have them come in for a flexible scope where we use a small camera, we look in the back of the nose, and we can actually see exactly what's going on there. And then if they do have a gap in the back, then sometimes I'll just send that message back to Dr. Mardini, and he'll figure out what he needs to do to make that better.
Okay, excellent. Is that usually a one-step sort of surgery process, or is it a multiple surgery going forward?
The surgery itself, depending on how much of a gap there is, there are different procedures.
Okay.
Dr. Cofer also offers a very innovative procedure where, in a relatively simple way, you can close that gap without having to do major surgery.
Okay.
And you've done hundreds of those procedures with huge success.
Yeah, we use tissue filler, just like if you wanted to go and get your lips augmented or plumped up, we can do the same thing.
Interesting.
Some procedures, some bigger gaps require redoing the palate again, putting the muscles in a better position. Sometimes initially they scar in a way that is not favorable, so we bring it apart and put it together in a way that gets the palate closer to the back so that there is a seal.
Okay, excellent. We have one last audience question here, which I think is a good one to end on. Is a craniofacial clinic something that all kids with clefts should attend?
I would say the short answer is yes.
Yeah.
I think that's the best way to get your care coordinated, to make sure you're getting looked at from all the different perspectives and angles, and it takes a team.
And obviously we're talking about Mayo Clinic's Craniofacial clinic and Cleft clinic, but there's other locations around the U.S. So if parents are not close to Mayo Clinic, there's other places they could seek out. So that kind of leads me to my last question. So what kind of resources would you recommend for families that have recently had a child who's been diagnosed with a cleft or some other type of craniofacial syndrome?
So first of all, I think all of us on the team, Dr. Bite, Dr. Cofer, and I, are willing to help in any way. If a child needs help and they have questions, I think we're all willing to call and say, here's what we can offer you here, or advice to where they're going to go. So I think they can feel comfortable doing that. But if you want to talk about the things, the resources that are available, please, if you share some of the things.
So
that
I would say I would direct families to American Cleft Palate Association website. They list all of the certified cleft teams in the country, and I would definitely go with one of them.
And that gets back to that patient question too, right? Of really finding that craniofacial clinic. Okay.
And then there's lots of other, blogs and things like that. There's that cleft team, the cleft community likes to talk about their experiences, and it's really good. It's a supportive environment.
Absolutely. For I have a child with a chronic illness, and those can be really, really helpful as a parent going through it and trying to navigate the system. So absolutely. We also have a resource on an online blog community called Mayo Clinic Connect, and the website will be up on the screen for families that are looking for other ways to connect in a Mayo Clinic supported environment. So excellent. This was wonderful. Thank you both for joining us and sharing your time and expertise with us.
Thank you.
Thank you.
Thank you, everyone who watched and joined the conversation today. If we didn't answer your question, we will try to get to it after the broadcast. You can catch the next Ask the Mayo Mom on Facebook Live on Mayo Clinic's Facebook on July 26th at 11 a.m. Our guest will be Dr. Edward Ahn. He is a new pediatric neurosurgeon at Mayo Clinic and will have lots of expertise to share. Thank you, everyone. Have a wonderful day.